Imagine you go into the hospital to fight this really deadly disease, right?
Right. Yeah.
You're bracing yourself for the surgeries, the intense medications, but the absolute first thing the nursing staff does is ban your family from bringing you fresh flowers.
Yeah, and they might also, confiscate that unwashed apple your friend brought to snack on.
Wow, really?
Oh, yeah. Or they'll banish a perfectly healthy-looking visitor just because they, cleared their throat out in the hallway.
That is wild. Well, welcome to another deep dive. Today we are taking you into the absolute gauntlet of breast cancer oncology.
It's a heavy topic, but a really important one.
Definitely. And we're working from this really fascinating set of clinical notes. They cover everything from the initial diagnostics all the way to the intense post-operative nursing care required to keep a patient safe.
Yeah, the whole spectrum.
And our mission today, right, it isn't to just read you a textbook or rattle off a boring list of symptoms. We really want to decode the actual clinical journey of this disease.
Right, tracing it from the microscopic misbehavior of a single cell all the way to those surprising, highly specific rules of recovery.
Exactly.
What's fascinating here is that these notes provide a literal roadmap of how medical professionals act as detectives, strategists, and caretakers, basically all at the same time.
Yeah, they really do.
Although it is probably worth mentioning to you, the listener, that our source material today has a bit of a unique character to it.
Oh, yeah. A few quirks.
Right, the transcript these notes were pulled from had a few audio gaps and some mysterious transcription errors.
Like the phantom medication.
Yes, there's a medication somehow transcribed as Duin, spelled D-U-Y-I-N.
Which is definitely not a real oncology drug.
Not at all. But despite those quirks, the core clinical data paints a remarkably vivid picture of the oncology battlefield.
So we're going to decode all that data.
Hmm.
But before we can look at how doctors attack the disease, you really have to understand how the disease operates on the battlefield of the human body first.
Right. You need to know the enemy.
Exactly. Like what is actually happening in the breast tissue to kick this whole terrifying process off?
Well, the clinical notes pinpoint this fundamental malfunction regarding a cellular process called apoptosis.
Apoptosis.
Yeah, which is programmed cell death.
Okay.
So in a healthy body, your cells have a strict lifespan. They perform their function, they eventually get old or, sustain some damage, and then they undergo apoptosis to make room for new, healthy cells.
So it's basically just tissue renewal.
Exactly. It's a totally necessary mechanism. But breast cancer cells, they mutate in a way that allows them to completely bypass this cycle.
Oh, wow.
Yeah, they just refuse to undergo programmed cell death. And because they don't die off when they are supposed to, they multiply unchecked.
Okay, let's unpack this.
Yeah.
Because it sounds like normal cells have this built-in self-destruct button for when their time is up, but cancer cells have basically snipped the wires to that button entirely.
That's a perfect way to put it. And because those wires are cut, a single microscopic error can rapidly snowball into a billion-cell tumor.
Just from one error.
Right. Instead of the body naturally clearing out a defective unit, that defect becomes the blueprint for rapid, uncontrolled replication.
It's terrifying when you think about it like that.
Sure.
And the notes also point out a really surprising detail about where these rogue cells prefer to, set up camp.
Ah, yes, the adipose tissue.
Right. Adipose tissue, meaning fat tissue.
Hmm.
The notes specifically state that the adipose tissue plays a key role in the tumor microenvironment.
Yeah, so the tumor formation actually hijacks the local physiology.
Hijacks it.
Yeah, that adipose neighborhood basically provides an environment where these mutant cells can really dig in and thrive.
Wow.
And once that unchecked growth begins in that specific microenvironment, it inevitably starts to produce observable physical changes.
Right, which is where you see the medical professionals' detective work begin.
Exactly, because eventually that microscopic rebellion becomes visible to the naked eye.
So if you're a nurse or a doctor conducting a physical assessment, the notes list some very specific visual clues you are hunting for. You might see dimpling or retraction of the skin on the breast. There could be noticeable changes to the nipple itself, like inversion or an abnormal discharge. You might see generalized inflammation. And then there is a highly recognizable sign called peau d'orange.
Peau d'orange, right,
Okay.
which translates from French to orange peel.
Okay.
The skin of the breast actually thickens and takes on the pitted appearance and texture of the outside of an orange peel.
That's so specific.
It is.
So you have these visual red flags, but a massive part of the assessment is physical touch.
Yeah.
Palpation.
Yes. Palpation is huge.
The notes mention that when palpating a mass, you are assessing its temperature, like If it feels unusually warm and its texture,
Mhm.
is it soft or does it feel pebble-like?
Right.
But they put a massive emphasis on mobility.
Yeah.
And I'm trying to picture the physical mechanics here.
Okay.
If a doctor is checking whether a lump is mobile, meaning it like slides around under the skin, versus fixed,
Mm.
does a fixed lump mean the tumor is literally growing roots and anchoring itself into the surrounding tissue?
Yeah, that is a very accurate way to deduce what's happening beneath the surface.
Oh, really?
Yeah. A mobile lesion often indicates a less serious condition, like maybe a benign fluid-filled cyst. It might displace the tissue around it, but it doesn't invade it.
Gotcha. It just pushes things out of the way.
Exactly. But a fixed lesion strongly suggests the mass has physically tethered itself to the surrounding fascia or the chest wall.
Oh, wow.
It is actively invading the space, not just floating in it, which makes it a major indicator of potential malignancy.
That makes total sense. So you find a fixed lump, or maybe you notice that peau d'orange skin texture. Observation alone isn't enough anymore, right?
No, not at all.
You have to pivot to gathering hard data to confirm exactly what kind of threat you're dealing with.
And this introduces what we call the diagnostic funnel. You start broad to capture any potential issues, and then you systematically narrow things down to get a precise, localized picture of the disease.
I like that. The diagnostic funnel. So at the widest part of that funnel, you have your early detection and screening.
Right.
These are the tools you use to catch something before there are obvious alarming symptoms. This includes self-breast exams, clinical breast exams performed by a provider, and mammograms, which the notes emphasize should start at age 40.
Yes, age 40 is the baseline there. Now, if a screening catches something suspicious, or a physical exam reveals a lump, you move further down the funnel to diagnostic investigation.
Okay.
This involves much more targeted imaging, so a diagnostic mammogram for higher resolution, an ultrasound to determine tissue density and whether a mass is solid or fluid-filled,
Right.
an MRI for a comprehensive soft tissue view, and then ultimately a biopsy.
The biopsy being where you actually pull the cells out and test them.
Exactly.
And if that biopsy confirms cancer, you have to find out if it has spread beyond the breast. You move to the absolute bottom of the funnel, which are staging tests.
Right, checking for metastasis.
The notes list CT scans, PET scans, bone scans, and chest x-rays. Actually, wait, looking at the staging tests here,
Yeah.
the notes also mention checking PSA levels. Isn't PSA prostate-specific antigen used exclusively to screen for prostate cancer?
It absolutely is. Seeing PSA listed in breast cancer staging notes is almost certainly one of those mysterious transcription errors we noted at the beginning.
Like our phantom medication doing.
Yes, exactly like Duin. It serves as a great reminder that when you are reviewing raw clinical data or, transcribed medical lectures, you have to stay sharp and contextualize the information.
You wouldn't run a prostate lab for breast cancer staging.
Definitely not.
Good to know I wasn't losing my mind reading that section.
Mm.
So, ignoring the rogue prostate test, a massive piece of this investigative phase is receptor testing, which is also known as testing for tumor markers.
Right. Very important step.
The notes specify testing the biopsy tissue for estrogen receptors, progesterone receptors, and this protein called ERR2.
Mm-hmm. The medical team is essentially trying to figure out what the tumor is eating. Yeah, what is fueling its rapid growth? If a biopsy reveals a tumor is estrogen receptor positive, it means the cancer cells have receptors that lock onto the patient's own naturally occurring estrogen, and they use that hormone as a signal to multiply.
Okay, speaking of estrogen, this perfectly tees up something I really want to push back on.
Oh, okay.
Because when I was looking at the risk factors outlined in these notes, some of them threw me completely off guard.
Really? Which ones?
Well, look, things like being female, being over age 50, being of American or European descent, having a family history, or carrying inherited BRCA1 and BRCA2 genetic mutations.
Yeah.
All of that tracks logically for anyone familiar with breast cancer.
Sure. Those are standard, well-documented primary risk factors. They're heavily tied to genetics and just the aging process.
Right. But then the notes list these other primary risk factors that feel completely disconnected to me.
Like what?
Like having your first intercourse before age 15, starting menstruation early, reaching natural menopause late, like after age 55, or a term called nulliparity, which means never having children.
Yes.
How on earth does never having a baby or the age you first had intercourse increase your risk for breast cancer?
Well, if we connect this to the bigger picture and pull back to look at the timeline of a person's life, Those seemingly random milestones all point to one specific biological reality:
Okay.
prolonged exposure to cyclic estrogens.
Oh, wow. So it's literally about the sheer volume of time the body spends bathes in that hormone.
Precisely. Starting menstruation early and reaching menopause late stretches the window of time where the body cycles estrogen every single month.
That makes total sense.
Right. And pregnancy actually pauses that estrogen cycle. So, never having children or having them much later in life means fewer interruptions to that lifetime estrogen exposure.
What about the early intercourse factor?
Well, early intercourse is commonly used in clinical histories as a proxy marker for early hormonal onset. Yeah. These aren't just random, disjointed events. They are chronological clues indicating a higher lifetime volume of cyclic estrogen, which, as we just established, acts as fuel for those receptor-positive cancer cells.
Wow. It makes the diagnostic phase feel less like taking a snapshot and more like reviewing a patient's entire biological autobiography.
That's a great way to look at it.
So you've gathered all this estrogen and receptor data. The detective work is done, but diagnosing the cancer is only half the battle, right? Now you have to neutralize it without destroying the patient's body in the process.
Exactly. And the clinical notes outline the surgical and medical modalities used to achieve that really delicate balance.
Right.
The surgical route depends heavily on the staging we discussed earlier. A lumpectomy removes just the tumor and a small margin of surrounding healthy tissue, aiming for breast conservation.
Okay, whereas a single or bilateral mastectomy involves removing one or both breasts entirely.
Yep.
And the notes mention a radical mastectomy, which is even more invasive.
Yeah.
They take out the breast tissue, the underlying chest muscles, and the surrounding lymph nodes to ensure they've cleared every possible avenue of spread.
Yeah, it's very extensive. And alongside surgery, you have the medical therapies.
Like chemo.
Right. Hormonal therapy is deployed specifically to block the estrogen we just talked about, effectively starving those receptor-positive tumors.
Mm-hmm.
Radiation therapy targets localized remaining cancer cells, and chemotherapy uses systemic agents designed to circulate through the entire body and aggressively stop rapidly dividing cells from replicating.
See, here's where it gets really interesting and honestly a bit terrifying for the patient.
Yeah.
Chemotherapy doesn't have a homing beacon just for cancer cells. It targets anything in the body that divides rapidly, which includes hair follicles, the lining of the gut, and crucially, your white blood cells.
Yes.
The notes detail a severe consequence of this called neutropenia, Neutropenia.
Neutropenia is a dangerous, steep drop in neutrophils. Neutrophils are a specific type of white blood cell that basically act as the immune system's first responders. When chemotherapy wipes these out, the patient's immune system is essentially obliterated.
Oh, I was trying to visualize this. Imagine your immune system is a medieval fortress.
Okay, I'll get that.
You've got your neutrophils acting as elite guards, standing on the walls, fighting off every bacteria, fungus, and virus trying to breach the gates.
Right.
Chemotherapy comes through and basically wipes out your entire garrison. The fortress is left completely unguarded.
And in that unguarded state, a minor pathogen that a healthy person wouldn't even notice, like the bacteria found in tap water or everyday dust, that can be lethal.
Wow.
Because of this reality, the notes detail these fascinating, extreme precautions that the nursing staff must enforce. They essentially create a sterile bubble around the neutropenic patient.
The rules for this bubble completely explain the hook we started with today.
Yeah.
Mandatory masks are obvious.
Mm.
Hospitals might even use positive pressure rooms, which physically push clean air out into the hallway so contaminated hospital air can't drift in when the door opens.
Exactly.
But the everyday items that get banned are what really struck me. No fresh flowers allowed in the room, and absolutely no raw fruits or vegetables.
Think about it. If you consider the soil a flower grows in, or the microscopic fungi resting on its petals, or the bacteria clinging to the skin of an unwashed apple,
Yeah.
to your healthy immune system, those are trivial. But to a neutropenic patient without their guards on the wall, a beautiful get-well bouquet is a biological hazard teeming with opportunistic infections.
It completely reframes how you look at a hospital room.
Yeah.
And you have to consider the psychosocial impact on the patient, too. At the exact moment you're going through the most grueling, terrifying physical treatment of your life, you are forced into this intense isolation.
Yeah.
You can't have visitors who even have a hint of a sniffle.
Mhm.
You can't receive traditional comforting gifts.
And the notes emphasize psychosocial support heavily here because the care team has to navigate not just the medical frailty of the patient, but the severe emotional toll of being treated essentially like they are allergic to the outside world.
That's heartbreaking.
It is. Deep empathy becomes just as critical as clinical precision.
And that empathy has to carry right over into the next phase of the notes, life after surgery.
Right.
Because once the tumor is out and the patient survives the chemo and that neutropenic bubble, the battle shifts. Postoperative care introduces a strict new set of rules to ensure the patient heals safely.
This is especially critical if the surgery involved the removal of lymph nodes, which is very common with mastectomies to check for cancer spread.
Mhm.
The lymphatic system acts as a crucial drainage network for bodily fluids. When you remove nodes from under a patient's arm, you compromise that drainage system on that entire side of the body.
So what does this all mean for the patient's day-to-day life? The notes describe what I can only call the VIP arm.
The VIP arm, that's a good term for it.
If you've had lymph nodes removed from under your left arm, that left arm is suddenly subject to absolute non-negotiable protections.
Right. The primary goal there is preventing lymphedema, which is severe chronic swelling caused by the buildup of lymph fluid that can no longer drain properly.
Sounds painful.
Very. To prevent this painful condition, the arm has to be protected from any trauma or constriction.
And the precautions are incredibly strict. You can never have a blood pressure cuff placed on that arm. No IV sticks, no blood draws, no injections of any kind. You can't do any heavy lifting with that arm for 6 to 8 weeks post-op.
You also have to avoid tight or restrictive clothing, remove all rings, bracelets, and watches that might impede circulation, and you are explicitly instructed not to sleep on that affected side.
There was one detail that highlighted just how fragile this system is. The notes specify that if lymph nodes near the ear or neck were removed, the patient can't even wear earrings on that side.
Yeah, even that minor trauma of an earring could be enough to trigger a swelling response.
Crazy. The arm basically lives on an elevated pillow to help gravity do the work the lymph nodes used to do.
Although the notes do provide one clinical nuance for you to be aware of.
Oh.
Yeah, while the overarching rule is to avoid all skin punctures on the affected arm, some specific facility policies might allow a minor blood sugar finger stick if absolutely necessary, but you must always verify that facility's specific policy.
Right. It is an exception, not the rule.
Exactly.
Now, aside from managing the VIP arm, the chest itself requires intense recovery management. Because of the complex nerve endings in the breast and chest wall, pain management is a huge nursing priority. Patients are often placed in Fowler's position.
Right. Fowler's position involves sitting upright at a 45 to 60-degree angle.
Right.
This decreases swelling in the chest cavity by promoting drainage, and it also makes it much easier for the patient to take deep breaths and cough, which is crucial for preventing post-op respiratory issues like pneumonia.
They also rely on surgical drains, like Jackson Pratt drains, those little squeeze bulbs you might have seen that create gentle suction to pull excess fluid away from the surgical site.
Mm-hmm.
And while they are healing physically,
Mm-hmm.
they are simultaneously trying to rebuild their strength nutritionally, which sounds like an absolute uphill battle.
It really is. The lingering effects of chemotherapy and radiation include profound nutritional barriers, anorexia, nausea, and severe taste alterations where food literally tastes metallic or like cardboard.
That's awful. To combat this, the dietary strategy shifts to high-protein, high-calorie interventions to fight muscle loss and promote tissue healing.
Yes.
The notes recommend frequent small meals focusing on easily tolerated foods like eggs, tofu, fruits, and vegetables to maintain baseline energy.
But true recovery isn't just about draining fluids and counting calories. The notes place a massive responsibility on the nursing staff to address body image and psychological healing.
Yeah, because a mastectomy or a lumpectomy permanently alters a person's body.
Exactly.
The notes outline the options that the care team discusses with patients to help them navigate this new reality and reclaim agency over their appearance.
Right.
They discuss breast prostheses, which are padded forms worn inside a bra to create a natural silhouette. They coordinate with plastic surgeons for surgical breast reconstruction to physically rebuild the tissue. They even utilize specialized nipple tattooing to visually recreate the areola and nipple after it's been removed.
It requires a fully interdisciplinary approach. Dietitians, physical therapists, oncologists, plastic surgeons, and nurses all coordinating their expertise to ensure the patient doesn't just survive the disease, but actually recovers their quality of life.
It is a monumental undertaking. Looking back at everything we've covered today from these clinical notes, the journey is just incredible.
It really is a lot to take in.
Right. From understanding how a mutant cell cuts its own apoptosis wires to thrive in an adipose neighborhood, to the tactile detective work of feeling for a fixed lump anchoring itself to the chest wall. From recognizing that a timeline of a person's estrogen exposure is actually a cancer risk profile, to the heartbreaking isolation of the neutropenic bubble and the strict, lifelong rules of the VIP arm.
It is an immense amount of clinical logic to synthesize into one cohesive picture of patient care.
It really is. But whether you are a nursing student trying to memorize these assessment findings for your clinical exams, or you were simply a curious learner wanting to demystify the medical world, knowing the why behind these things matters.
Definitely.
When you understand why there's a no fresh flyers rule, or why early menstruation is a risk factor, it makes you a more informed, empathetic advocate. It helps you advocate for your own health and for the people you love who might find themselves navigating this exact battlefield.
You know, this raises an important question, though, a thought to leave you with.
Oh, I like those.
If we look back at the tumor marker testing we discussed, where early diagnostics involved testing tumors for estrogen and progesterone receptors to see if they are essentially feeding on the body's natural hormones.
Right, hunting for their fuel source.
It forces us to ask, how much of combating cancer in the future might rely not on attacking the tumor directly with aggressive chemicals that wipe out the immune system, or invasive surgeries that permanently alter the body, but by fundamentally altering our own body's internal ecosystem.
Oh, wow.
If we can master how to safely manipulate the hormonal and cellular environment, could we reach a point where the cancer simply has nothing left to eat?
That changes the entire landscape.
Yeah.
Suddenly, you aren't just fighting the rogue cells, you're changing the rules of the environment so they can't survive in the first place.
Exactly.
That is a fascinating place to leave it. Thank you for taking this deep dive with us. We'll see you next time.